So current standard of care, at least in the US, is based on the NCCN guidelines. These are guidelines that are updated twice a year, and I'm part of the panel. So for upfront treatment, we have a randomized study to show that if you have certain subtypes of T-cell lymphomas that express CD30, the standard is now brentuximab vedotin-based combination chemotherapy. Brentuximab vedotin is a CD30 targeting ADC. And it can be combined with chemotherapy agents like CHOP with some modifications. It's actually BV plus BV plus CHP without the vincristine. And that's really the standard for CD30 positive T-cell lymphomas based on randomized good clinical data. For non-CD30 expressing T-cell lymphomas, the upfront treatment is still listed in the NCCN guidelines on an alphabetical order. It's usually CHOP based or some form of that, CHOP, CHOEP, EPOC, Hyper-CVAD. Some of the rare subtypes like hepatosplenic T-cell lymphoma don't do so well with CHOP, and again, those are very rare, so the data is very scarce, but at least in the NCCN guidelines, other options are things like ICE or Hyper-CVAD. If you have relapsed disease, there are a couple of approved agents for relapsed T-cell lymphoma. Pralatrexate is one of them, has about a 30% response rate. You have romidepsin and belinostat. These are two HDAC agents that are HDAC inhibitors that are approved for T-cell lymphoma in the US that are available to patients. Romidepsin actually lost its approval by the FDA, but it is still available for cutaneous lymphoma patients, and I have had no issues getting it for my T-cell lymphoma patients as well. There is also brentuximab if you have, as a single agent, if you have relapsed disease and it's CD30 positive. There are a couple of new clinical trials ongoing that will probably lead to approval of some other agents. A PI3 kinase inhibitor, for example, duvelisib may be the next agent. But there's a lot of clinical trial data ongoing, clinical trials ongoing, and hopefully we'll have some data that will support approvals and expand the treatment options for these patients in the standard of care setting rather than a clinical trial setting.